Hello there, welcome to the patient assessment review. Just wanted to cover some basics on both trauma and medical assessments. I know you've been through this already in your courses, you've discussed this, you've read about it, but I wanted to remind you about what you need to do when you go through your dynamic patient simulations. So bear with me. So first of all the steps in your patient assessment, whether it's medical or trauma. And actually later on in this, you'll come to the realization that there really are no separate skills in the field. We just have one assessment and we modify it to fit the patient's presentation. But we'll talk about that later. First thing, of course, you have your standard precautions on, whatever's appropriate. Now, with all this COVID stuff going on, you're talking about gowns and N95 masks and goggles and gloves and whatever's appropriate. You can have those on prior to arriving at scene. You, of course, will have ensured scene safety. And remember, scene safety is a dynamic, ongoing process that never, ever, ever stops until you are at the hospital and you've turned that patient over to someone of a higher authority, or in the field to someone who's equal or higher authority if you're doing it out in the field or at scene. Really what it comes down to, your scene size-up never ends. Just keeps going all the way through. People have a tendency to walk on scene, seeing safety, then they get tunnel vision, and they miss those important clues that's telling that the scene is now potentially no longer safe. I know you have learned about mechanism of injury versus nature of illness. One's a medical problem and one is a traumatic injury. Just remember that this might come across your dispatch. You may be over the pager or radio or computer, however you're going to receive your calls. They're going to categorize the patient in one of these two categories. It's a traumatic injury, it's some type of illness, but remember, it's could be anything. So keep an open mind, read the notes, but remember, it could be one, it could be the other, or it could be both. We're, of course, going to check for a number of patients, probably as you're arriving at scene, as you're pulling up at scene in your ambulance or your fire truck or your lifeguard vehicle or whatever you might be working at. You're going to count people. You're going to get a general idea of how many patients. It seems like one patient. It seems like 5 patients. It seems like a busload of patients. And just before getting out of your apparatus, you're going to call for additional resources. And this can include helicopters, more ambulances, more fire trucks, police, rescue, or whatever you can imagine. You can call for. It's a really good idea to call for it early. And then if it turns out you don't need it, you can always cancel it. And then finally, we're always going to consider spinal stabilization on every single patient. The reason why this is because imagine if you go to a patient who's having chest pain and you walk up, hi sir, what's going on? I have chest pain. And you're going down that cardiac medical route. And then during your assessment, he says, oh yes, I was sitting in my chair. I had really bad chest pain. I fainted. I fell out of the chair and hit my head and my neck hurts. So now you have a medical patient who has a traumatic injury from their medical problem. Would you put a collar on them? I would. So it's a good idea to just always consider spinal stabilization throughout the entire call, because the call, again, is very dynamic. It can change. Now, once we get through our scene size up, we go into our primary assessment. And you've been through these steps before. You probably have read the skill. You've read about it in your textbook. You've watched some videos that we have. And the first thing we do is we want to form a general impression. And all this basically does is it gives us a snapshot of the patient. I'm sure a lot of you, I know myself included, have gone to parties, social events, and I meet someone for the first time, and I just hate that person. And it's just some weird chemical thing going on. I have no idea what it is. And what I have found though is my very first impression of this person is usually not that far off. They probably are dirtbags. So you can almost transfer this to your patient assessment. As you're walking up, you're getting just basically a snapshot, a gut feeling of what's going on. What do they look like? Do they look stable? Do they look like they need a lot of help? So it's just that quick little kind of impression of stable or unstable, essentially. If you see any life threats, as you're walking up, there's blood squirting from their neck. Well, of course, you're going to stop that bleeding. They have a sucking chest wound. As soon as you recognize any of the life threats, and this could be no breathing, no pulse, arterial bleeding, sucking chest wounds, those are all obvious life threats, need to be treated right here and now. Once that's cleared, you're going to talk to the patient, you're going to make contact with the patient, you're going to use AVPU. So are they alert? Are their eyes open? Do they only respond to your voice? Do they only respond to painful stimuli? Or are they unresponsive? And then at some point in your call, you're going to get a Glasgow Coma scale. I'll talk about that a little bit later. At this point, we're going to determine chief complaint. If the patient is awake and alert, we're going to ask the patient why they called today or what's going on today. And they'll tell you whatever it might be. I tripped and I twisted my ankle on the trail. I'm having chest discomfort. I have back pain, whatever it might be. That's their chief complaint. Just remember that someone might call you for a very minor chief complaint, something like a twisted ankle. And as you're doing your assessment on their chief complaint, you discover something more serious, more emergent. So in this case, this would become your provider impression, and then that would become their chief complaint, that whatever you found. I'll give you, for instance, I had a gentleman who cut his finger cooking, and he had a pretty good laceration to the index finger of his left hand from just chopping vegetables, I guess. And he called 911, go figure. And by the time I got there, the bleeding had stopped, and he felt a little embarrassed, and he wanted not to go to the hospital. So I said, sure, no problem. And he signed a release of liability. You learned about AMAs and all that probably in your medical legal chapter. And while I'm going through this documentation process, I happen to notice that he had this really bad leg infection going on, this really bad cellulitis going on in his legs, which is actually a fairly serious medical problem. And I pointed it out to him, and he had no idea he had it. So that suddenly now became his chief complaint, and he wound up actually going to the hospital. He wound up getting admitted and spent a couple of days in the hospital getting treatment for that. So remember, you got to be flexible about this. Once you have a chief complaint down, you assess your A, B, and C. So is the airway open? If it isn't open, you open it. You suction. Provide some kind of adjunct as necessary, whether it's an oral or a nasal pharyngeal airway. Check their breathing. Is it adequate? Is it inadequate? Get their lung sounds if it's appropriate at this time. Maybe it's an asthmatic or someone complaining of respiratory distress. This is a good time to get their lung sounds. Apply oxygen as necessary. And remember that 94% or above generally does not need oxygen. In some cases, they do, but in most cases, they don't. Check your circulation, which means pulse. And at this point, you're just getting snapshots. You're just getting 10-second. How's the pulse feel? Is it fast or slow, strong, weak, regular, irregular? You're not really counting numbers. And you're going to check for uncontrolled bleeding and, of course, their skins. If this were a trauma patient, then you'd also look at any injuries that might be causing them to have problems breathing. And you might have recognized a state of shock at this time, so you might even have considered starting your shock protocol, keeping them warm, and high flow oxygen and all that. By this time, and primary assessments can last 30 seconds, they can last 2 minutes, however long it takes you to get through this. Based on these initial findings, you're going to make your transport decisions. Is this person stable? Can we stay here and talk more? Or do I need to move this person rapidly to the hospital because his life is in danger? Now, AVPU, like I mentioned before, remember, alert just means as you walk up to them, their eyes are open. It does not mean that they're oriented. So we walk up, you say, "Hi, sir. My name is John. I'm here to help you. I'm an EMT. What's your name? Where are you right now? And do you know what day it is, or what month it is, or what year it is, whatever works for them." And if it's a trauma patient, you might consider asking about, do you know what happened to you today, the event? If their eyes are not open, they might respond to verbal. They might respond to their name or your voice by opening their eyes. They might say hi to you. They might raise their hand. Those are all responses to verbal. So then in that case, they're V on the AVPU scale. If they do respond to you by your voice, then you can ask them, "Sir, what's your name? Where are you? The time and the event as well." So you can still check their orientation, possibly if they can respond to you. If they don't respond to verbal, you provide a trap squeeze, a painful stimuli. And there's two basic types of response. One's called purposeful response. This is going to be localizing pain or withdrawing from pain. So either they push your hand away from their shoulder, or they withdraw away from you. And now, non-purposeful types of painful response would be decorticate posturing. This is called flexion posturing, or cerebral posturing, which is extension posturing. And these are non-purposeful, which means the person's brainstem is doing this now, not his brain. So it's kind of telling you that the brain is severely damaged one way or another. Now, of course, the U in AVPU is unresponsive to pain. You do the trap squeeze, you yell at the person, whatever it is, no response whatsoever. Ultimately, if this person has an altered mental status, whether they're just disoriented or whether they're unconscious, no matter what their problem is, whether it's a medical patient or whether it's a trauma patient, their chief complaint is they're altered. So this person crashed his car, he's got a massive head injury, he has an altered mental status. This other person is having a massive heart attack, causing him to have an altered mental status. So he has an altered mental status secondary to his medical complaint. I just wanted to go over the Glasgow Coma scale. You will be using this during both the medical and trauma dynamic simulations. Be familiar with the three components of this: eyes, verbal, and motor. It's a total of 15 points. So 15 means you're awake, you're alert, your eyes open spontaneously, you follow commands. Be able to factor this on your simulation days. And realistically, in the field, actually working in the field, you will be performing a Glasgow Coma scale on every single patient you encounter. It's a county protocol. Now, just a quick summary of your primary assessment. You form that general impression of the patient. Are they stable, unstable? Get their age, possibly, sex, position of the patient as you found them. Assess the level of consciousness. Look for life threats. Find out their chief complaint. ABCs, oxygenation, control the airway, establish patient priorities, and you're done with your primary. Remember, the primary can take 10 seconds or it could take 2 minutes, depends on the status of the patient. So you can see with this patient right here, you have this person, you're called to the park for this altered male. PD's at scene. And the friend called because he couldn't wake his friend up or the patient up. So scene size of considerations, of course, is a scene safety issue here. This might be a drug overdose. It might be used needles around. It might be weapons, so that's a consideration there. Your BSI, of course, is a consideration. You walk up to the patient, you see that the young man in the picture right here, he doesn't appear to be alert. You walk up, "Sir, sir, sir, wake up." No response. Trap squeeze, no response. Next thing you're going to do is you're going to get him off that bench and onto the ground so you can work on him. Or you can transfer him to your gurney if the gurney is right there. You want him kind of in a supine position to work on him. You're going to check ABCs. His airway has vomitus in it. You're going to suction. He does not appear to be breathing effectively, uh, and he has a very rapid, weak pulse. At this point, you know you have a B problem and an A problem. You suction the airway, and you have your partner do back valve mask ventilations. And once you get that done, now you can go and work your way into your secondary assessment. You got to treat all those life threats first, and make sure that ABCs are done. He still has a pulse and all that. During this process, you notice there's a needle in his arm, and he's got pinpoint pupils. This is a narcotic overdose, so you know that at some point you will be administering naloxone hydrochloride or Narcan. So you might consider inserting a nasal pharyngeal airway rather than an oral pharyngeal airway because you're anticipating this future treatment. Now, secondary assessment. We kind of learned that with the primary assessment, the key points, the key purpose of the primary assessment is one, determine for life threats and treat them. Two is to establish our chief complaint. And three, just determine how bad off our patient is essentially. So we have this person, we've opened their airway, we've suctioned their airway, we're doing bag valve mask ventilations on this patient, we've inserted a nasal pharyngeal airway, and now we want to investigate the chief complaint. So the purpose of the secondary assessment is to investigate the chief complaint. In this case, with this gentleman in the previous scenario, his chief complaint was an altered mental status secondary to a drug overdose. So we're going to investigate the chief complaint, and we're going to provide whatever appropriate treatment that he or she might need. So there's three basic components of every secondary assessment. And the reason why I have it set up like this is because you can move these three components around any which way you want to fit the patient's presentation. So you learned about sample history, sample questions. This is when you find out about what happened, basically. You talk to the patient, you talk to the bystanders. You're going to get some kind of baseline vital signs initially, and at some point, you're going to do some type of physical assessment, touching the patient, exposing the patient, looking for injuries, looking for signs of what's going on. But what order you do this in depends on your patient's presentation. If the patient's awake and alert and stable, they're the best historians. They have the best story for us. So it really behooves us to ask sample questions first, because then we can get a pretty good story of what happened. While we're asking sample questions, we can have our partner, because we are always going to have a partner, EMT partner, firefighter partner, and hey partner, could you get me a set of baseline vital signs? So as you're asking sample questions, your partner's getting a blood pressure, pulse, respirations, O2 saturation, skins, blood sugar, whatever you think is appropriate. Now that you have a sample questions done, you have your baseline vital signs done, you have a fairly good idea what's going on, and then you can focus your physical assessment on that one area. So for instance, this person's having respiratory distress. You're asking him those questions about his asthma, and you go through this, and your partner gets baseline vital signs. You note that this patient has low oxygen saturation levels. You apply high flow oxygen to the patient, and now you have this person stabilized, and now you're going to do a physical assessment on his chief complaint, which would be the area of his torso, his chest. You're going to listen to his lung sounds. You're going to look for signs of trauma to his chest. You're going to look for retractions and accessory muscle use and grunting respirations and all those things that are associated with someone having problems breathing. On the other hand, like the guy in the picture in the last scenario, this guy's lying down on this bench, unresponsive. He can't really answer your questions. So what we have to do is we have to then focus on our physical assessment, do what's called a head-to-toe assessment. And while we're doing the head-to-toe assessment, looking for any signs of trauma or medical problems Why? What we're trying to answer here is, why is this guy not responding to us? So while I'm doing the physical assessment on this patient, doing head to toe, my partner can then get a blood pressure, get a pulse, get a blood sugar level uh, on this patient. And then at some point while we're doing this, I could turn to his friend and ask, hey, what did he take today? I noticed there's a needle in his arm. What was in the needle? So you can see where I focus primarily on an unconscious patient or an altered patient. I focus on the physical assessment first. And the person who's awake and alert and able to answer their own questions, I try to focus on the sample side first. Now, OBQRST, it's really only for medical patients, and usually only works pretty well with respiratory or pain type of complaints. You will need to know this, of course, for your dynamic simulations. So the onset, the two questions associated with this is, what were you doing when it started, and did it come on fast or slow? Provocation just means what makes it better or what makes it worse. So provocation, palliation. So, sir, is there anything that makes your discomfort better or worse today? He might say, if I walk around, it gets worse. When I rest, it gets better. Quality. Ask them in a couple of words, can you describe how it feels? And they'll say it's tight, it's heavy, it's sharp. Whatever it is, that's what it is. Radiation, reoccurrence, and region, so the R. So radiation, does that discomfort move anywhere else? Does it come and go? That's reoccurrence. And the region can have them point to where they're hurting today. And this works for headaches, stomach aches, back aches, chest pain, works for all those. Severity, of course, is on a scale of 1 to 10, and it's very, very subjective. So you might smash your thumb with a hammer and it could be a 10, and someone else it could be a 3. So whatever they say it is, that's what it is, gives us a baseline. So if the person says I have a 10 out of 10 scale pain, you intervene with treatment, and now after the treatment they say it's a 4, then that tells you that whatever you're doing is going in the right direction. And then finally you want to ask time. When did this start? How long has it been going on for? Along with this, you need to ask specific special questions that are associated with this person's condition. For instance, someone who's having an asthma attack, you could ask them things like, have you used your own inhaler prior to our arrival? Have you been sick recently? Have you ever been intubated with an advanced airway? Have you ever had to go to the hospital and get intubated with an advanced airway? So you can ask specific questions about that particular chief complaint. Same with, so you can see with medical patients, you're going to ask more than just OPQ or ST. You can ask them things like, like a chest pain patient who's complaining of right substernal chest discomfort, which is kind of atypical for chest pain patients, and you find out that it radiates through to their back underneath their right scapula, and now you're thinking, well, this might not be cardiac related. It might be something like a gallbladder attack or something like that. So now you start asking, well, when was your last meal? What did you eat? Have you ever had a gallbladder attack before? Are you vomiting anything? Is it green bile coming up? So basically now this is cluing you into, this might not be cardiac related. It might be something else going on. You have to dig a little deeper, ask some of those questions about the patient, about their history, see if you can narrow it down. Now, special questions, we talked about the respiratory complaints, things like getting air in, getting air out, trouble getting air in, getting air out, any cough, any sputum coming up with that cough. Have you been struck in the chest recently? Those kinds of questions relate to respiratory. There's dozens and dozens of them, just a few I can think of offhand. Cardiac, you can always ask, of course, the OPQRST questions, but then you can ask, are you nauseated? Are you short of breath? Are you dizzy? If in the sample history you find out they have a cardiac history that had previous heart attacks, You could ask them simply, does what you're feeling today feel the same as when you had your previous heart attack? And they'll say yes, or they say no, it's different, or yes, it's the same. So again, that helps you focus on what's going on. Stroke, of course, most important question for a person having a stroke, either talking directly to the patient if you can, or talking to a witness, is the time of onset. Remember that strokes are time sensitive, just like cardiac patients. They're all time sensitive types of things, but strokes are particularly time sensitive. So we want to keep it down to that 6-hour window. And that 6-hour window is a County of San Diego protocol. So we want to ask them, when were they last seen normal? When do you think the stroke came on? Are you on any blood thinning medications? Have you hit your head recently? Have you been in a car accident recently? Because this might not be a stroke. This might be a bleed caused by a blow to the head, which sometimes can mimic certain kinds of strokes. Allergic reactions, ask them what they're feeling, a lump in their throat, shortness of breath, difficulty speaking, tightness, things like that. What were they exposed to? Has it ever happened before? And how were you treated? And remember, you were going to have an epinephrine pen on the ambulance, and you can treat them directly based on standing order here in the County of San Diego. Psychological emergencies, this is going to be the person who's having a severe depression or anxiety, schizophrenic patient, bipolar patient going through one or the other phase. And this person, because of this onset, they can't function in society. And one thing about psychological emergencies is they don't come on overnight. They don't come on in a few hours. They come on over a period of weeks and weeks. So if you listen carefully to the history from the patient or the history from the family or caregivers, you're going to hear a history of probably the person stopped taking their medications and they've been gradually getting worse to the point now that they are no longer manageable and they can't function in society, and that's why you get called. So you ask these questions. Probably the top 2 questions you want to ask any psych patient is, do you feel suicidal and do you feel homicidal? Do you want to hurt somebody or do you want to hurt yourself? The next question, the third question, is going to be, have you been taking your medications? They're probably going to say no, but who knows? Childbirth, if the woman is in her 3rd trimester and she's ready to, ready to go, so to speak, she's having contractions, you want to know things like how far apart your contractions are, how long each contraction lasts. Does she feel the need to bear down, kind of have a kind of sensation of having a bowel movement? There's all kinds of other questions you can ask as well as you're setting things up. You can ask her things like, any complications with the childbirth? How many children have you had previously? How many pregnancies have you had previously? One thing you don't ask her is, don't ask her a pain scale. On a scale of 1 to 10, how bad are your contractions? She'll probably punch you. So that's inappropriate. Overdose, or even underdose, I guess. This would be what they took, how much they took, and why they took it. Most people who overdose, that I encounter anyway, do it on purpose to kill themselves. Usually heroin addicts, drug addicts that have any kind of experience with their addiction are pretty good about dosing themselves okay. The only exception is if a really, really pure concentration of drug comes through the streets and they're not prepared for that higher concentration, that could happen. But most overdoses that I encounter, and you probably will encounter in the field, are going to be drug overdoses that are on purpose to try to end their lives. Ask them what they took, ask them why they took it, how long ago did they take it, did they vomit after they took it, how did they take it, did they inject it, did they snort it, did they, obviously wherever it might go. Nowadays, who knows, sometimes people put it in their rectum, women put it in their vagina, it's all kinds of, it's free game basically when it comes to people taking drugs nowadays. And of course injury. What happened? Again, this is that A&O times 4. They know their name, they know where they are, they know the day of the week, and they should know what happened. Well, I was walking up on the scaffolding, I tripped over a nail, I fell 20 feet to the ground. Great. Did you pass out? Great question. Did you pass out before you fell? You can only imagine someone could be up on the scaffolding painting a wall, they have a stroke or a seizure or a heart attack, they become unconscious, they fall off the scaffolding. You arrive on scene, you get there and they're awake. You might just think this is a trauma patient. Well, it's actually a medical patient, a stroke patient, or a cardiac patient, or a seizure patient who's fallen and now has a traumatic injury. So unless you do a really, 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 really good assessment, you're going to miss that. Now, when it comes to your physical assessments, we've done our sample history based on when we thought we needed it. Your partner has already gotten your baseline vital signs for you, so you have some idea of what's going on. You determined that there are no immediate life threats. Those were taken care of, hopefully, in your primary assessment. And now you have to decide, well, what kind of assessment am I going to perform on this person? A rapid head to toe or a modified assessment? So when it comes to a rapid secondary head to toe, it really comes down to your choice. But if you think about it, if this person has a significant traumatic injury, or at least the kinesmatics of what happened is severe. This guy was driving his car at 100 miles an hour. It rolled over 5 times. Very significant mechanism of injury, or this person has a very serious medical condition going on. I would definitely perform a head to toe. Remember, my head to toe is not just for trauma patients. In fact, when you do a head to toe, you should not just look for traumatic related problems. You should look for things like needle marks, dialysis grafts or shunts, any kind of implantable devices, medical devices, anything that might tell you why this person might be altered or in the state they are in right now. If this person has an altered mental status to the point where they can't communicate with you, well, then you need to do head to toe. This person has 2 broken arms and a broken leg because a car hit them. Well, of course, you got to do a head to toe while you're packaging the patient. Or anytime you consider a patient to be unstable, I would consider some type of head to toe assessment on this patient. It never hurts. It's actually, even though based on the video that you probably watched for this particular skill, it looks like the head to toe takes forever. And the only reason why it takes forever is because you're obviously going to be tested on it. But in the field, a head to toe can take 10, 20, 30 seconds. And by that time, you're ready to package them up and move them towards the hospital if they're critical. Now you learned about IPA, inspection, palpation, and auscultation. So you always want to look before you touch. So inspect, then you touch, you palpate, and then you auscultate as appropriate. The only thing we really auscultate, the only thing we really listen for with our stethoscope are lung sounds. So IPA applies to the whole body, but really the A part really only applies to the lung sounds. We listen for things, and of course, we smell for incontinence or vomitus or chemicals or something like that. Hopefully, you learned about DCAT BTLS. As you're going through all patients' assessments, I'm not just talking about trauma assessments, I'm talking about medical assessments as well. You're going to be keeping your eye open for DCAT BTLS. And you can use this during your assessment if you like. If you do decide to use DCAT BTLS, you need to state to the teaching assistant or whoever is grading you what it means. So if you're going to use it, be prepared to explain what it means. Now, the head to toe rapid assessment is pretty obvious. It starts at the head. I'm going to check the scalp, the face, I'll check the pupils, and because we're looking for everything, both medical and trauma, we're looking for a deviated gaze, which is a sign of a stroke. We're looking for any kind of bleeding from the nose or mouth. We're looking for any bleeding from the ears or cervical spinal fluid from the ears or nose, looking for all that stuff. Checking the pupils for a pearl. And once we get done with the face and the head, we go to the neck. We check the anterior, posterior surface of the neck, looking for decap ETLS, descended neck veins, deviated trachea, signs of trauma. Apply a cervical collar if that's appropriate. If this person needs a collar, this is time to apply it. You expose the chest. You're inspecting the chest for signs of decap ETLS. You're going to listen to lung sounds. You're going to palpate the chest, feeling for crepitus. Crepitus are the bones crunching or rubbing together from broken bones, crunching, rubbing together. You're going to feel for stability of the chest, rise and fall of the chest, and you're going to auscultate those feels, at least those anterior feels anyway, for the chest. Go down to the abdomen. You're going to inspect the abdomen. You'll palpate all 4 quadrants, looking for bruising, distension, rigidity, guarding. Then you go down to the pelvis. You expose the pelvis, and you're going to stress the pelvis and the pubic bone, and you're going to see if there's any stability or instability. If the pelvis is unstable due to a fracture, you need to stabilize it with some type of stabilization device. Most departments use blanket wraps or pillow wraps, and there are actually manufactured stabilization devices, but they're usually not seen in the field because they're so expensive. Once you're down to the pelvis, you go to the legs and the arms. You're going to check both legs and arms for decap ETLS, check for, like I said, needle marks, any kind of medical things going on there, even medullary tags. Maybe they have a tag says I'm a diabetic or I have seizures. And then going to get a pulse, motor, and sensation distal in all 4 extremities. When the whole front of the body's done, you then log roll them or sit them up, whatever is appropriate, and you're going to check the back, get posterior lung sounds, check the spine. Again, check for any signs of bruising, any decap ETLS back there. And at this point, if they are going to go onto a spine board, this would be the time for them to be moved onto a spine board, or if they're going to sit up semi-Fowler on the gurney, you could lift them up and place them on the gurney, or even have them stand up and sit on the gurney, depending on the circumstances. Remember, as you're going through this head to toe, you might see a life threat that you hadn't seen before. As soon as you find that life threat, and in this case it's probably going to be bleeding or sucking chest wound, you immediately treat it. You stop the bleeding with your hand, you cover the sucking chest wound with your gloved hand, and then you have your partner come in and take care of that problem. Now, most of our patients do not need head-to-toe assessments. Most of our patients do really well with a good old modified secondary. This is a person that has no significant injuries. The kinesmatics are not significant, so there wasn't a high-speed crash. He did not fall from a height. He does not have an altered mental status. He only has a single injury, and there's really no critical findings. This patient's awake and alert and can talk to us with a single chief complaint. This guy is appropriate for a secondary assessment. Now, when we approach our patient and we've done our primary assessment, we found out the chief complaint, he's fully oriented. We kind of found out what happened today to the patient. He gave us a pretty good idea of that. He fell and broke his arm while playing soccer. He denies any other injuries. We've checked his head and his neck and his back. He denies any other injuries. He's not on any blood thinning medications. He's very stable. Your partner's done vital signs on the patient. Very stable patient. And now at this point, we're just going to focus on this person's arm, the broken arm. We're going to check pulse, motor, and sensation. We're going to splint, ice, and elevate, and transport the patient to the hospital if that's what he wants. This other gentleman in the chair, he's having problems breathing. We're going to get our chief complaint. We're going to treat his airways, breathing, and circulation. Maybe give him some oxygen, a cannula, or a mask, or whatever is appropriate. We're going to find out his medical history, what happened, maybe ask him OBQST, questions about his medical history and how this all came on. He only really has the one complaint. He's an asthmatic, he has problems breathing. So we're going to focus on the breathing. So we're going to expose the chest. We're going to listen to lung sounds. We're going to check for accessory muscle use on the chest. And that's all modified essentially at this time. We're going to treat and transport the patient. Now you're called to the 65-year-old male who fell off a ladder. So you're seeing size up. Get your gloves on. It's one person. It appears to be a traumatic injury. We could probably handle it ourselves, and I'm definitely going to consider spinal stabilization. We walk up, we see the patient on the ground. He's holding his knee. He says his knee hurts. He landed on his knee. There's obvious deformity to the knee. So your partner's going to hold spinal stabilization right now, just in case, because we can't really rule out C-spine just yet. And we're going to check his airway, breathing, circulation, his level of consciousness. He's fully oriented. He has full recall of the event. He's breathing fine. He's talking in full sentences. His pulse is great. His oxygen saturations are wonderful. So his ABCs are totally intact at this time. So pretty much your primary assessment is done. So now you go into your secondary assessment, and now you got to investigate what's going on here. Now, you've already spoken to this gentleman about, what's going on a little bit, but now you need to investigate like really what happened here. So you ask what happened. And what happened to this guy was he was up on this ladder trimming his tree, and he got really dizzy, and he fell onto his knee, and he has actually a broken knee or cracked knee. So even though the knee is a problem and the knee will have to be addressed with a splint and like that, you're more concerned about the dizziness. So you ask him questions about like his medical history. Well, he's a diabetic. He's had strokes previously. He's had two mini strokes previously. He's on blood thinning medications for those mini strokes. So you do a stroke assessment and you find that he has facial droop and he has slurred speech. This is all new for him. So now this call started out as a trauma assessment or a trauma call, and now it's kind of gone into a stroke call with a secondary knee injury. You're still going to put a collar on this guy because he's 65 years of age and he basically needs a collar. You're going to put him on the gurney in some kind of semi-Fowler position. You're going to splint his knee, and you're going to transport him rapidly to a trauma center to get checked out. And again, most trauma centers are also stroke centers, just in case, right? A good place to take them. And then reassessment. So when it comes down to reassessment, we should do reassessments at least every 15 minutes. It could be every 5 minutes, whatever you think is appropriate, but once at least every 15 minutes, you should have at least 2 or 3 assessments documented on all calls. If there's any changes in the patient's status, you should reassess. If the person wakes up, they were once unconscious and they wake up, then I would check, hey, what's going on? How you doing, sir? If they were oriented and they went unconscious, I would reassess definitely there. Anytime you intervene, so you give this person nitroglycerin, you give them epinephrine, aspirin, whatever medication you might be intervening with, I would reassess this patient after a couple of minutes after you give the medication. And anytime you feel it's necessary, stop and reassess your patient. The steps of reassessment is simply repeat the primary assessment. So that comes down to your general impression again. Sir, you okay? Hi, what's your name? ABCs. Just basically do a quick primary assessment. Reassess your vital signs, the appropriate ones anyway. If you're concerned about blood pressure, get a blood pressure and a pulse and look at their skins. If you're worried about some kind of respiratory thing, get their lung sounds and their breathing and their pulse oximetry or whatever it might be, or all of that stuff, whatever you want to do. Repeat your secondary assessment. If it was a focused assessment, go back and refocus on their chief complaint. If it was a head to toe, redo your head to toe just very quickly. Check your interventions. Make sure the oxygen is still flowing, the splint isn't too tight, whatever it might be. And then just keep an eye on the patient the entire call to make sure that there aren't any changes in the patient's status so you can catch them early and intervene early on.